Welcome to Deep Dive Dialogues on Hematological Malignancies from Diagnosis to Personalized Treatment, where we navigate the landscape of blood cancers to explore the latest advancements and personalized approaches in diagnosis and treatment. Our distinguished guest today is Dr. Gurleen Oberoi. Dr. Gurleen is an accomplished hematopathologist with extensive training from prestigious institutions such as AIIMS Delhi and SGPGI Lucknow. She is currently serving as the senior consultant and lead hematopathologist at National Reference Lab, Dr. Lal Path Lab Private Limited, Delhi, and has been instrumental in launching high-end tests. She is a program director for the fellowship program in hemato-oncology at NRL and is also part of editorial committee of Indian Myeloma Academic Group and various national and international societies. She is an expert in reporting bone marrow, flow cytometry, FISH, and molecular testing. Dr. Gurleen is highly regarded as guest speaker, faculty member, mentor, and expert panelist in numerous national and international conferences. So welcome, Dr. Gurleen.
Thank you for this introduction, Dr. Mani.
Yeah. So Dr. Gurleen, could you see that how does diagnostics play a crucial role in precision medicine?
So I think diagnostics is most important, and the starting of the precision medicine in the sense that first you identify the biomarkers like genetic mutations, the molecular markers, the protein expression on these cells, and it also these biomarkers which we identify by diagnostics helps in response in assessing even the response to therapy. So definitely in precision medicine, it is important from identification, the first precise diagnosis, to personalized risk assessment, in which, like if I give an example of AML, on the basis of the markers which we detect, it can be stratified into favorable risk or intermediate risk or adverse risk, and on that basis the therapy is decided and the follow-up is decided of these patients. Apart from that, it is also important in targeting therapy. So if we know the exact diagnosis, we can plan the therapy better, first of all. Over and above the diagnosis, the specific genetic profile also directs the therapy more effectively. So if we know that the patient is BCR-ABL positive, then the targeted therapy for that, the imatinib, the dasatinib, or nilotinib can be used for targeting the therapy. And thus, a better I would say outcome for the patient is ensured if we focus on the first part, that is the diagnostics. And after targeting the therapy, the next step comes as disease monitoring. The diagnostics is important there as well. So when the monitoring has to be done, the MRD assessment by molecular technique or by imaging or flow cytometry, it ensures that and tells us how the patient is responding to therapy and whether the therapy needs an intensification. The duration of therapy is decided. The transplantation is decided, whether the patient needs a transplantation now or after some time. So everything depends on these diagnostic techniques, and it is a partner to the therapy, I'll say, on every step. And the clinical trials, the selection of the patients for the drug development, we also need the diagnosis or diagnostic markers stratify these patients to one group, and then these development of the drug or the therapy is done. Depending on the group they are in. So it is also important in developing the therapy as well. So in the research work as well.
Yes, I agree. So what is the journal diagnostic approach in hematological malignancies?
So generally, everything starts in the clinics. So right. The clinical history is very important. The patient is examined, what all, or if there is an organomegaly, how the patient is presenting, if there are B symptoms. On that basis, the clinician first orders the peripheral blood or the CBC of the patient. So if there is any cytopenia or or any abnormal cells which are seen in the peripheral blood, or so on these basis the further therapy is decided, further course is decided, which is bone marrow aspirate and biopsy. So the bone marrow aspirate is an invasive procedure. So before that we have to be sure or what we are looking for, why we are doing it. The indication should be very clear. So when the bone marrow aspirate and biopsy is done, on then the morphology gives us an idea of infiltrations, the leukemias, the lymphomas, and the marrow aspirate which we get, that can be utilized for specific tests like flow cytometry, uh, genetic testing, NGS, to determine these specific genetic markers, prognostication of the patient, and to take a therapy decision as well. So this is the way we go about, and after that, imaging is needed, like in lymphomas, PET-CT scan. And other imaging techniques are needed to know how much the disease has spread in the body. So these are very important, and it has to be taken in a right approach to reach a proper diagnosis. This is the general approach.
Correct. Right. So, how has the integration of genomics enhanced the diagnosis and understanding of hematological malignancies?
So I would say the genomics, this is the era of genomics.
Yeah.
Even the WHO classification of hematological malignancies is now completely based on genetics. And to begin with, from the diagnostics, the subtyping of these hematological malignancies is based now more on genomics, and it is becoming this mainstream line of diagnostics right now. Yeah. So if I give you an example, if there is BCR-ABL positivity, then it can in ALL and in CML, then we'll know that this is a pH positive disease. If it is negative, we'll know that we have to go ahead and go for a further testing for JAK2, CALR, MPL for the pH negative MPNs, which are polycythemia vera, the essential thrombocythemia, or primary myelofibrosis. So these completely guides the diagnostics right now to a very specific diagnosis, which helps in deciding the therapy, in prognostication, in risk assessment, in the monitoring of these patients. So to give you an example of AML, where if there is a FLT3 mutation in the AML, we know that is a poor prognostic. So if that one information is with the clinician, that the patient is a FLT3 mutated AML, which is a poor prognostic marker, and the follow-up will be decided like that, and it is a targeted and we have a targeted therapy against it. Yeah. So the target for FLT3 mutation like midostaurin and gilteritinib, these will be incorporated in the therapeutic strategy of the patient. So genomics is helping the clinicians and the patient a lot. And I would say that not only in the leukemias and the lymphomas as well, like if there is a BCL2 positivity along with BCL2, BCL6 positivity in a double in a DLBCL patient and a double hit lymphoma, it becomes double hit lymphoma, which is much more severe and has a chance of relapse and a refractory disease in the future. So the disease therapy or the therapy will be personalized that way for the patient. So genomics play a role in this. Then the monitoring. In the monitoring, we know that if we know a specific mutation, like in AML or ALL, if the mutation is known, like in APML, if we know PML RADA is positive, we can follow it up and see the MRD positivity and use that for guiding the therapy in the patient. So definitely, it is important, very crucial.
Yes. So, how does flow cytometry contribute to tailoring treatment strategies for individuals?
So I would start with like flow cytometry. Even when you see the scattergram of the flow, you can actually tell that there is a disease. When you see the 45 expression and there is a dim 45 expression, you have an idea that this is a leukemia that, rather than lymphoma. If you go with the lineage marker, the specific lineage marker, you will understand that there is a disease of lymphoid lineage or a myeloid lineage, or it's a plasma cell related disorder, or an erythroid or a megakardioplastic sort of lineage disorder. So just from the beginning, two lineage markers, you have an answer that you are dealing with a lymphoma, a leukemia, a myeloid leukemia, or a lymphoid leukemia. And after that, those specific aberrant markers also give us an information of whether the patient is having a poor prognosis, like an AML. If there's a 56 positivity, we'll have an idea that there is a chance that the patient won't respond well to the therapy and it's going to have a poor prognosis. Same goes with CLL. If we have, there are markers like CD38, SAP70. We know that these are poor prognostic marker, which are also a part of risk stratification of these cases. So flow cytometry, to begin with, diagnostics, then prognosis, and then MRD assessment as well. So in comparison to genetics, molecular MRD, flow cytometry MRD also helps in stratifying the patient, the risk stratifying at the post-therapy level as well.
Yeah.
So we know that we can further plan the therapy if we know that the patient is having MRD positivity on flow. And further, uh, very important is it has a role in hematopoietic stem cell transplantation. So if there is a information of stem cell enumeration, so so the quality of and the adequacy of those graft is determined by the flow cytometry, by knowing the stem cell enumeration, exact stem cell enumeration. That and this technique helps in that. Apart from that, post transplantation as well. In the post transplantation, whether the patient's immune system has reconstituted. So the immune system reconstitution is also can be tested by flow cytometry, in which lymphocyte subset, T cell, B cell, NK cell subset is analyzed, and we can have an idea of immune reconstitution in the patient. Apart from that, even in the immunotherapy, which is the newest therapy and the most effective therapy, the CAR T therapy and all, if we know that the patient is having a CD19 positive disease, then we can go for CD19 CAR T cells or other immunotherapy targeting these specific markers which are coming out to be positive. These flow cytometry markers can actually give you a clear idea about a molecular abnormality also. Like if there is a HLA-DR and 34 negativity, we can have an idea that the patient is having APML with a high side scatter. The scatter is always important. It has to be analyzed by an expert, where in these small points are observed and documented and discussed with the clinician. So flow cytometry can play a very important role in precision medicine as well.
Right, right. So now the comparison comes. So how does high throughput sequencing perform compared to flow cytometry for detecting minimal residual disease, that is MRD in hematological malignancies?
I would say both are very good, crucial, and everything, but definitely there are drawbacks and advantages of both the techniques, and it is depending on the disease we are looking for assessment, and the sample which we have, and the third thing is what was the at baseline molecular abnormality or immunophenotypic feature. On that basis, the clinician and the pathologist decide what test has to be taken done. So because in case of the molecular MRD is usually done when there is a specific molecular abnormality is present in the patient, that only can be followed up in the future and can be used for the MRD assessment. These can be fusions, specific gene mutations. These more specific molecular markers has to be present for assessment of the MRD in the treatment course. But what goes against molecular MRD, we have to have those baseline transcript preserved, and the patient has to send the sample to the same lab for the lab to access that and use it for the MRD assessment first. And if there is a disease heterogeneity, then also there can be an issue if this heterogeneity is not having their subclone related mutations. So those subclones will be missed by the molecular MRD. So first the molecular marker should be present. That mutation, the specific mutation which has to be tracked, has to be present in the baseline at the time of the diagnosis, which can be tracked further. And secondly, the subclones should be representative, and then the heterogeneity should have particular mutations for have a representing MRD assessment to follow the patient for the monitoring. In case of the flow cytometry, the benefit is the applicability. It is more in most of the cases, even if the mutation is present, not present, it can. These markers can be tracked. The flow cytometry markers, the protein expressions can be tracked, and the MRD assessment can be done in a very large number of cases and diseases. In comparison to the molecular MRD, the constraint is the molecular abnormality in the molecular MRD, and in flow cytometry, the drawback is usually the sample quality. So it depends a lot on the sample quality. If there is degeneration, if there is marker expression loss or immunomodulation post-therapy. So if there is a marker which is present in the baseline, post-therapy, there can be immunomodulation which has been studied now. Like in and specifically with advent of immunotherapies, the CAR T therapies, the specific targeted therapies like daratumumab for CD38. So if we take an example of the plasma cell MRD or multiple myeloma MRD, if we are doing multiple myeloma MRD, the 38 and 138 are the gating markers initially. So if usually these anti-38, which is daratumumab, if it is used, then if we are doing an MRD, we can face some problem. However, we are coming up with new markers like 319, 3229, which mitigates this issue as well. But definitely, the immunomodulation of 10, 34 in acute leukemias, of 38 post targeted therapies, the 19 CAR T therapies in lymphomas and leukemias. So these actually creates a lot of problem for the hematopathologist to track the disease by MRD, by flow cytometry. So these are the basic differences, but definitely it has to be disease specific. We have to always take the option of MRDs, both molecular and flow, depending on the disease and these characteristics.
So they complement each other. Right. So, yeah. So with this, we conclude today's session. It has been wonderful talking to you. Thank you, Dr. Gurleen, for joining us. Stay connected, all of you. Thank you all for joining.
Pleasure. Thank you.